Hello, everybody. My name is Lisa Cairns. I work at St Oswald Hospice in Newcastle upon Tyne. I'm going to be the first to admit that this is new technology for me too, so just bear with me and hopefully this will go really well. This morning I'm going to talk about hypnosis and hospice care, and I'm going to talk a little bit about past, present and future. And I'm going to share my journey as well about how my career has developed and changed, quite often influenced by patients and families. So I will talk through the PowerPoint that I've prepared, and there's a video at the end. I'm very happy to take questions. If I don't know the answer, I will find out. We'll certainly get the answer to Ruth once I've found out. So I'm just going to go for it. Basically, the title, Hypnosis and Hospice Care, Past, Present and Future. So that's just an introduction to the PowerPoint. Thought I'd set a little bit of a timetable just to outline what I'm hoping to cover today. I'm hoping at the end of the talk, you know a little bit about St Oswald's Hospice and what we do, a little bit about my background, but predominantly I'm hoping that you'll know a little bit more about hypnosis and how I use it, how I've developed it and how I'm hoping to take it forward in the future. And I've got 3 case studies. Hopefully will just illustrate some of the work that I've done over the years. So basically, St Oswald's, who are we? We're a charitable hospice rooted in the northeast, provide outstanding specialist and expert care to adults and children with life-limiting conditions, and we strive to provide quality time for everyone. So who we are, so we opened in 1986, we're in Gosforth in Newcastle. So in 2021 we'll be 35 years old. In 2021 I'll have worked at the hospice for 22 years. I suspect I will retire from here in some shape or form. Originally I was intending to stay here for about 4 years. But like I say, 22 years later, I'm still here. So we care, who we care for, so babies from 0, children, young adults, adults with incurable life-limiting conditions, and we care for families and carers too. This is our story is a video that you can find on the website. So if you look at the St Oswald's website, there's a video that you can click on, and it just gives you a little bit more insight into the hospice and our approach to hospice care. And you can see some of the building, our lovely staff showcasing what they do. I thought it was probably important to touch on COVID, because obviously, like everybody else, we've been affected by this awful virus. And I think as a hospice, we've tried to adapt very, very quickly to all the changes that happened sort of February, March and April. We've had to adapt our services because obviously patients still need care, even though we're in the middle of a sort of pandemic. So basically our services focus on living, which some hospices may call day hospice, sort of day care. A lot of our services we switched to video and telephone contact with patients. We had an online resource hub and sharing, and online group sessions, certainly an art group session. They were a really active, you know, lively craft group who came into the hospice, and that was a real hub of activity and you know, a lot of happy times in there. So basically the group have stayed together but online. So there's been the whole thing of trying to get used to new technology and trying to support patients in adopting the technology as well. Lymphedema, our nurses, usually that was again, patients would come to us. So some of our nurses have started to do home visits, again using video and telephone contact, more complex cases, obviously COVID safe, bringing people on site when we need to. The inpatient unit, the children, young adults has remained on site, and we have had some visitor restrictions, but we've constantly adapted and updated. Obviously we're very keen to keep families and patients in touch and together as much as we possibly can or we're allowed to. And we've had to get used to PPE like everybody else and sometimes adapting and doing jobs that we wouldn't normally do, just to keep the place moving and keeping the services going. So I'm going to move on from COVID, talk a little bit about me and my journey. So I qualified as an occupational therapist in 1992 at the Dorset House School of Occupational Therapy. Came to St Oswald's in 1999, and after a few years of working on the inpatient unit as an occupational therapist, gained the opportunity to train in clinical hypnosis. That was with London College of Clinical Hypnosis. Absolutely fantastic course, loved every single moment of it, and was really hooked on hypnosis because I really felt that it could make a difference. 2015, I tried to take this hypnosis a little bit further with a PhD, because at that point I had some treatments that I'd developed and I wanted to show how successful they were. How do you measure success? And that started a whole new academic journey for me. Coming forward to this year, I'm very pleased that I've been given an honorary title of a visiting research fellow at the University of Sunderland, which now I'm going to use to support the ongoing work from my PhD and the work I've developed since. So that's sort of my past, present and future a little bit. I'm going to click onto this photograph. Again, my journey and my background. And really, I think that although I trained in 2002, I think probably a real linchpin in my hypnosis career and training and thought was a patient that, here she is, a picture of her in 1944, a lady called Dorothy Morton Corner. Now, 52 years later, our paths crossed at St Oswald because she was diagnosed with motor neuron disease. Probably at the time that I was just about to qualify, and she asked me if I could help her with hypnosis with a number of symptoms, including managing drooling of saliva, because her swallowing was affected, so she was plagued with oral secretions that she felt really impacted on her quality of life. My response when she asked, can you use it to control saliva, was, I don't know, but I'll find out. And that was sort of the start of my big journey, really. So she's been highly instrumental and inspirational, really, over the last few years. So I want to move on now to hypnosis, because a lot of people that are referred to me for hypnosis, they don't know an awful lot about it. They might have seen it on television, on stage shows, they might have heard stories about it. What I tend to say to people, and I've sort of over the years put my own spin on this, is that actually hypnosis, it's a natural state of consciousness in which a person is open to suggestions. But I think the really reassuring thing for people, and sometimes they're quite surprised, is that actually in hypnosis, the person remains in control at all times. In fact, all hypnosis is self-hypnosis. So I think it's trying to just reassure people about that. Now, I've mentioned suggestions. People are more open to suggestions, and I think this is something you potentially see on the stage shows and people, you know, doing silly things and stuff like that. But actually, a person will only take on acceptable suggestions. And actually, part of the process of starting to work with someone in hypnosis is finding out what those acceptable suggestions are and putting my spin on as a therapist. Why don't we use these suggestions? I think they'll help. I think the other thing to emphasize is that each person's experience is unique. There will be techniques that I use that are very similar for each person, but each person's journey is different, and I have to and enjoy adapting to that. The therapist does not have control over their patient at any time, and I think it's trying to emphasize that to people as well. What I usually say is I have 2 teenage daughters and I never have control over them, and it won't let me use hypnosis anyway, but basically you don't lose control in hypnosis, and it is a natural state. And sometimes people say, what does it feel like to be in hypnosis? And I always say to them, the best way to describe it is, if you're driving along a familiar road, you've done the journey many times, or if you're on public transport, and sometimes you will get to your destination, there'll be parts of the journey that actually you can't quite remember because your mind was wandering a little bit, but you were still in control. That is what I would call natural hypnosis. So it's something that we can all do to engage in therapy. It's something that you want to do. So basically, that's probably important for everyone to know. A lot of people ask me who can benefit, and hypnosis is used for a lot of conditions. When we were training, things like stopping smoking, weight loss, managing anxiety, depression, lots and lots of conditions. What I say to people is anyone can benefit if it's something that you want to do. What I say to my patients that are referred to St Oswald is it isn't limited by diagnosis, it isn't limited by disease stage. The reason I say about disease stage is some people with a new diagnosis say, well, maybe it's just a bit too early for me to start. What I would say to that person is actually, if we teach you the skills of hypnosis now, we can apply it and change it as necessary. And sometimes people that are more poorly and towards the end of their life will say, well, maybe it's too late for me to use it. But actually, I'm going to talk about a case study later on that hopefully will demonstrate how I've used it at different stages of people's journeys. There are some contraindications. Certainly people that have epilepsy, some mental illness, we wouldn't be able to use the hypnosis with. Some cognitive change, but I have to say that actually being linked to a medical team and consultants, some cases, there are ways of working around things that probably at the outset of my training I would have said, oh no, I can't do that. I think particularly around cognitive change, a lot of the motor neuron disease patients that I work with have a form of frontotemporal dementia, and it comes down to individual assessment as to whether we can actually use hypnosis with that person. So it isn't limited, and I think it's always worth a discussion about, is this the right therapy for me? Can I benefit from it? Now, my referral criteria, I've had to sort of set this out, and I think it's developed over the years, and it's really about the areas that I feel I have specialist skills in. So basically, my referral criteria is around supporting patient engagement with treatment. Now, this I've used across the board with patients with a cancer diagnosis, motor neuron disease, Parkinson's disease, and it's things like claustrophobia is a real interest of mine. So claustrophobia, MRI scans are a big thing for a lot of our patients with a cancer diagnosis. Motor neuron disease patients, things around using collars, non-invasive ventilation masks, that kind of thing. Claustrophobia does come up quite a lot, so it's something I've developed a big interest in over the years. Needle phobias, anyone can have a needle phobia, but I have used it with a lot of patients going through chemotherapy. A lot of them that felt that they just couldn't contemplate starting treatment because of the needle phobia. And it's about how do we actually get that person through treatment and work with them on their phobia so they can actually get the help that they need. So supporting patient engagement with treatment. Going back to my lady, Dorothy Morton-Corner, I think the second criteria that I would say is the management of complex oral secretions, and that's for people who are unable to tolerate medication, so they might have an allergic reaction to it, or they may find that the medication dries the mouth up too much. And we're talking about the oral secretions that I work with, it tends to be watery saliva that the person can't swallow and then escapes from the mouth and it bothers them. It's a really awful symptom. So basically, people that can't tolerate medication or don't feel they're getting a big enough effect, and it's actually affecting their ability to take part in activities or do pleasurable things. Some of my patients are referred because they've tried medication. They might be on a waiting list for Botox injections or radiotherapy to the salivary glands, and they want to try something in between, because actually, if this would work, then potentially they might not try Botox or radiotherapy. But again, it's very individual. It's something that's discussed with the person's consultant. So it's basically a team effort, and patients remain on medications and medical treatment whilst I'm working with them. So it's a constant negotiation. Third one is the person rates a symptom as having a significant impact on daily activities or quality of life after medical treatment. So it may be that somebody has had Botox injections, got a partial improvement in the management of the saliva, but actually they're saying it's knocked my confidence, I can't do the things that I want to do. Is there anything that you can do to help? And thirdly, I use it for lots of symptoms in palliative care, where there's treatment, they've tried medical treatment, and basically the person still feels that that symptom is there and it's enough to actually impact on their quality of life. So things around anxiety, management, panic attacks, pain, nausea and vomiting, and sleep difficulties, I think, are probably some of the most common examples that I work with. And finally, well-being referrals to allow patients to access medical services. For example, transplant waiting lists, and I have helped people actually stop smoking. It's probably the only time that I use it to help people stop smoking, so they actually can get onto a transplant waiting list. And you know, I'm really pleased to say that some of those patients have actually managed to get onto the transplant list and receive a donor organ. So a really worthwhile piece of work, which I really enjoy. So what does a typical treatment program look like? And I think the first, certainly, I think referral, I look for an awful lot of information about a person. But also when the person comes to their first session, it's about listening, information gathering, and building a relationship, because I find that it doesn't matter how much you talk about hypnosis, it's until you've actually tried it, you've got to know me, your therapist, then people are always a little bit nervous. So I think first session is really, really crucial. And it's about identifying what is it you need to change. So it might be I want to reduce the amount of saliva that I'm producing, or I want to control panic attacks. What is it we need to change? I think the other question, and it sort of brings my occupational therapy hat in a little bit, and it's about, if we can make that change, what would you like to do? So what activities is this stopping you doing? And the third thing would be, who else needs to be supported or involved to make this happen? And sometimes that's family members, and it wouldn't be unusual for me to be using hypnosis with more than one person in a family. But sometimes it's also around supporting professionals and communicating about what we're trying to do and what we're trying to achieve, and it just helps everybody work together, and again helps with the person's symptom. Once we've actually got that relationship, we've done a lot of talking about what suggestions should we use, how does this affect you. Basically, we're then into the stage of trying to establish and reinforce the hypnosis. Now, first of all, I think find a new safe space, which, what on earth could that possibly mean? And I think for me, it's in an ideal world, if you're using hypnosis with someone, you're trying to teach somebody self-hypnosis, you need them in a comfortable position. So ideally you think, well, nice comfy chair, or lying on a bed in a nice quiet room. I find a lot of my patients, particularly the patients I work with more neuron disease, sometimes actually sitting in a chair isn't an option, or they're waiting for a neck support collar, or if somebody has a problem with saliva, they're quite often wondering, when I'm in hypnosis, what happens to the saliva? Is it going to immediately disappear? And can I actually dab my mouth? What do I do if I feel the saliva there? while I'm actually in hypnosis. So really a big part again about meeting that person, getting to know them, is working out what their safe space is. So it's about, where are you most comfortable for us to do this? Sometimes they come into the hospice, sometimes I'll see the person at home because that's the only place they've got a comfortable chair they can use. I think it's checking things out about what are you worried about. Quite often the saliva question, and actually that's something that we can work around if I know about it. So it's a case of, within the hypnosis, when you get new into your hypnosis and using all the different techniques we'll use, then it's okay to dab your mouth if that's what you want to do, because then what we say is, you can do that and you won't be disturbed. So it's about building that very individual plan around the person I'm working with, because if they don't feel comfortable, they don't feel safe in the space we're using, the hypnosis won't be as effective, and we're going to have to work a lot harder. Then moving on to techniques, scripts and suggestions. Now, there are lots of scripts and techniques that you can use to get people into what we call hypnosis, or quite often we use the word trance. But basically, I tend to keep it quite simple. And usually that involves asking the person to close their eyes and counting down from 10 to 1. And it's the way that I use my voice and pace, the scripts that we're using, that actually helps the person go into hypnosis. And really, what I say to people is, the worst that will happen is, I suspect, you'll feel relaxed. But you will be aware of what's happening, you will be aware of what's being said to you, you are completely in control. And before I even start, we'll have agreed on the suggestions that I'm going to use. And quite often it's around feeling relaxed, feeling comfortable, feeling calm, and waking up feeling refreshed. So basically there is the closing of the eyes, the counting down, which we call a deepener. Then you will do the therapy, which quite often involves a visualization with the suggestions embedded in that. And then ultimately, it's trying to teach the person self-hypnosis, so they can actually use the hypnosis when I'm not there. Some people, they can do it completely on their own. Other people need support, so they'll have a recorded CD. When I started this, everything was recorded onto a tape. Then we moved on to CDs. Now it's an electronic file that arrives by email, which then people will put on their iPads, on their telephones, so they've got their self-hypnosis available at all times. Then the application. So you've got to know your patient, you've got the hypnosis established, you've got them, hopefully you support them in using the self-hypnosis. So you've got all of that in place, and then it's about, how can we apply the hypnosis to support the change that we're after? And that's highly individual and unique to each person. And then it's looking at, how does this fit into the bigger picture? So basically then you start to look at, so we have your saliva a little bit more under control. How do we get you re-engaged with the activities and the things that are important to you? So it's, how does that fit in the bigger picture? And again, that's where my OT hat comes out again, because you start to look at the activity, break it down, and then try and apply that to the person. So first case study, this is actually one of my patients some time ago now, a young lady who's diagnosed with motor neuron disease at the age of 40. The onset was very much what we call bulbar. So basically speech, swallowing were difficult, and she had a lot of problems with saliva. It was impacting on her activities. She had retired from work, and she said to me, she was referred to me because she couldn't use medication. She was allergic to what felt like everything to her. And her words were, I can live with the fact that I can't speak. I can live with the fact that I can't eat anymore, but what I can't live without is my golf. I can walk around the golf course, but when I actually stand over the ball to take a shot, the saliva runs out of my mouth. So we had to come up with a treatment program that would work for her. So she responded very well to the hypnosis, very quickly started using a CD at home to reinforce the work we've done, very quickly moved on to self-hypnosis. And this is actually her playing golf post-treatment. Now, it's not a magic fix, it's not a cure-all, it's not a perfect outcome. How she used the hypnosis was she would drive to the golf course, use a hypnosis, and sometimes that was self-hypnosis in the car, or she would park the car up, listen to a CD, dry her mouth up, and it would remain dry long enough for her to have a game of golf. And that for her was a massive positive. So that was Caroline, and that's how we used it. And to break it down, what do you need to be able to do, how long for, how we're going to apply this, and a really good outcome. Now, I always talk about layers of hypnosis, and probably the different layers that I actually work on with people. So basically, you might be working directly on a symptom. So you might be working on saliva or anxiety that you're trying to reduce. In the background as well as teaching self-hypnosis, you're looking at boosting coping strategies. So it's around, confidence, feeling more relaxed when you're out in social activities, just giving that background boost. So you're always doing that in the background as well as working on the symptom. The other thing that I do is that re-engagement with activities. What do you need to do? If it feels like a really big activity, when on earth would I start occupational therapy, break the activity down, and let's work through each of these stages and try and get that person back into the activity. Won't be in exactly the same way as before, a bit like my golf lady. She could play golf, she couldn't go and have a coffee afterwards with her friends, but she could enjoy the golf. And it's negotiation, breaking the activity down. The last one, we quite often use the word dissociation from a symptom. And for some patients, actually, the relaxation and the escape and being able to take a break from their symptoms is huge. And earlier I was talking about how patients who are quite late in their disease, who maybe spend a lot of time in a chair or in bed and not going out very much, they use it quite successfully for that escape and taking a break. Always very important to know that person, because it's what visualization do you use if that person can't take part in that activity anymore. What do you use to help them relax that they can really enjoy? And for some patients, they'll say, oh, I just want to think about something totally different. For other patients, I'm going to talk about another patient called Cliff, who'll come up next. This was a gentleman who, again, had a diagnosis of motor neuron disease, who was prior to his diagnosis, very successful fell runner. And I met him sort of quite late in his disease, so he couldn't get out anymore, spent a lot of time in his chair, spent a lot of time in bed, was quite restricted in what he could do. But actually he really took on board the hypnosis and really loved it, developed it himself, almost. So I did all the groundwork, taught him self-hypnosis, and he developed it himself. And I'll read out, I asked him to actually type out what his experience of the hypnosis was. So I'll read out what he said. I focus on the sounds inside the room and outside the room. I acknowledge those sounds and then I let them fade, which is basically what I would say is basically moving himself into hypnosis, into trance, and actually just deepen it. Quite often I'll say to people, focus on the sounds you can hear, the ones that are not important, you can disregard for now. And that's what he's using there. Then I think about my favourite run. It doesn't distress me that I can't run anymore. In my mind, I can see myself warming up, and then I start to run. I remember the power in my legs, the air in my lungs, and the exhilarating exhaustion that only a long-distance runner can appreciate. My finish line is a stone wall, still cold from the early morning frost as I lean on my favourite stone. to catch my breath and enjoy that lovely view again. And that was something that he used pretty much every day. And I think, looking at what he read, we quite often, when we've got people in hypnosis and they're using visualizations that are very personal to them, use all of the senses. So it would be, so very much when we started this journey together, it was out St Cliff, and what would you be able to see? What would you be able to hear? What would you feel? What would you sense? So you create that lovely visualization for him. And for him, it was very, very powerful. And he said for 15 minutes, maybe once or twice a day, he felt like he escaped. And it worked really well for him. Now, how does the hypnosis fit in with St Oswald's Hospice? Because obviously I'm based here. Quite often what I find is that I am the first point of contact with the hospice for external referrals. So a lot of patients, because this is a service that I offer, patients will be referred to me. So basically I'm the first point of contact. I'm the person that they might meet. I will potentially be the person, might be the only person that they work with while they're here, and that's absolutely fine. So some patients will remain as a hospice outpatient, they'll come in and see me, or I'll see them at home. Once we've done what we need to do and they're set up and they're working with their hypnosis, it may be that then they're discharged. They have the option, if you need to come back to me or there's a query, just drop me an email and we'll get you back in. So that might be how that person chooses to work. Some people might start their journey at the hospice like that with me, and that's grand. Some patients, when they actually come to the hospice, they get a look at the surroundings, they get the feel of the place. You know, we've got lovely facilities, lovely, you know, the staff make every effort, like all the other hospices. So once the person comes in, might think, do you know, I might try something else here. And quite often I'll refer them into the Focus on Living Centre, where there's group work and activities, slightly different at the minute with COVID. So that might be that actually the person then accesses other services within the hospice and the wider team. So then they start to access physiotherapy, complementary therapy, and all the amazing services that we've got. It may be that actually I keep in touch with that person, but take a step back because actually the hypnosis is working. I don't need to be greatly and actively involved, and they're involved with the team. Some patients are referred, will see me as a hypnosis outpatient if symptoms develop at a later stage and they need to be referred to the inpatient unit. That again can happen. Some patients come to the inpatient unit and on discharge will be referred to me for hypnosis post-discharge. So there's lots of different routes, but quite often a lot of patients come in to the hospice through me. The next case study I'm going to talk about, Jeff, was somebody who I was the first point of contact for him. He came in to see me, engaged with the wider hospice, and used all of our services basically. And I think hopefully from the case study you'll be able to see the advantages again of how he engaged with the whole building. And this is Jeff in day hospice. I'll tell you a little bit about him. Again, a diagnosis of motor neuron disease. He was a pilot, small aircraft pilot. Actually worked as a computer programmer. Loved fossil hunting. Had a real zest for life. But anything, aeroplanes, aircraft, he loved all of that. And a really nice guy and an absolute pleasure to work with. He wanted to engage with activities as much as he possibly could. And his story started that he used to take his wheelchair as high up Northumberlandia as he could possibly go, so he could look over into an open cast area, and that's where he used to go fossil hunting. But because of his wheelchair, he couldn't go fossil hunting anymore. Because of his disease, he couldn't fly anymore, he couldn't go on aircrafts. Fully engaged with the hospice, I've got a video I'm hoping I'm going to hand over to Ruth in a minute to play the video, which actually just shows Jeff's journey and some of the things that we did with him as part of the wider team. I'll let the video run, Ruth, and then I'll talk a little bit about it. Okay. And now moving on to the future, as well as continuing with the clinical work. For me, I think probably the next stage is building the evidence. So now starting to look more towards research and actually looking at what I do in a little bit more detail. Partly because a lot of people ask me what I do, how I do it, can I share it, can I teach it? And to some degree, yes, but I think that actually needs to be rooted in the evidence before we can do that. So that's what I'll be doing next. Questions after the webinar. I'm not going to take some questions now if we still have time. I think anybody that's interested in being referred to the hospice or to see me, I think probably the best thing is to contact John Gregor, just to chat through and have advice, and then if necessary, John can contact me. Any professional queries about hypnosis that you might think at a later date, it's my email address. I'm very happy to respond to emails as best I can. Any inquiries about St Oswald's generally, then emails it to inquiries@St Oswald's, and they will do their best to answer questions or will refer to the person who can help. And thank you, and if there's any questions, I'm very happy to try and answer them.